Alrighty, everybody. Thank you so much for joining us today for Living and Moving with Arthritis. We really appreciate having everybody come in, and I love that we're able to offer these types of workshops to our membership. I want to introduce Dr. Jan Schroeder, who is the chair of the kinesiology department and a wonderful mentor and friend. And with that, I'll let her take it away.
Well, as Emily said, my name is Dr. Jan Schroeder. I go by Jan. Very few people call me Dr. Schroeder. And my area of expertise is actually exercise physiology with an emphasis in gerontology. So I really enjoy working with the older adult. I run a program down at Park Pacific Towers in downtown Long Beach. It's the 17-story building, residential building. So I run a program down there as well for older adults for them. So Emily asked me to come in today and talk about living and moving with arthritis. And let me just ask a quick question. How many of you are experiencing the twinges and the hinges? There's Ralph going on. Well, yeah, as we grow older, that's what we are going to be experiencing. So let's talk about arthritis. Yeah.
Before we start, can you tell us what you did to your foot?
Yeah.
You can talk about arthritis and boot on.
Eventually, that's where mine is going to be, right in that ankle. I want a big story. So we decided I either do skiing, mountain climbing, or riding the big waves, but it was nothing exciting. I actually have a partial tear in a ligament within my ankle. It's a chronic injury. Doing what we all love to do, which is exercise. Exercise is good for us. It really is. All right, so with arthritis, basic definition is it's an inflammation of the joint. And there are more than 100 different types of arthritis. So it's a very broad definition. With arthritis, in our nation, in 2009, there were about 50 million Americans that were affected. In 2030, which isn't that far away, 14 years, they're expecting about 67 million Americans to have some form of arthritis. Why do you think the big jump? 80 boomers. Yeah, we're getting older. Exactly. It's not we're doing anything wrong, it's just we're getting older. With it, if we look at kind of the breakdown of who experiences arthritis more than others, about 36 million of that 50 million is Caucasian, 4.6 million is African American, 2.9 million Hispanic, and then we go down from there. Why the difference between the ethnicities? No one knows. Exactly. We're not real sure why. We're not sure if it's a genetic issue, if it's an environmental issue. We're not real sure. With arthritis, it definitely limits our physical activity or our activities of daily living. Okay, and it really limits for some of us. How many of you feel that the twinges do limit you in what you can do sometimes? Maybe not all the times, yeah, but a lot of times it does limit. You're walking up that flight of steps, and the knee is like, oh, that's not feeling so great. Here's the interesting thing. You're like, oh yeah. It affects about 2 to 3 times more women than it does men. And again, we're not 100% sure why, but it might come back to an estrogen issue. They're not sure though. That's just one theory. All right, so the types of arthritis, as I said, over 100 different types. It's actually 107 right now. But the most common types are osteoarthritis. And osteoarthritis is a degenerative disease. So it means it's progressive. It starts and hopefully not, but typically it tends to get worse as we age. And it's really a progressive loss of cartilage. And what's cartilage? What do you think that is? Yes.
It's the material between bones to keep them from rubbing against each other.
Right. It's this little soft, pliable material that creates nice, easy movement. And when we start to lose that cartilage, things don't move as well, and that's when we start to feel the pain or the discomfort or the, just like the, something's not going on quite right type of feeling. Right, and our second biggest type of arthritis is rheumatoid arthritis. And with rheumatoid arthritis, it's different than osteo. Rheumatoid arthritis is an autoimmune disease in which the body turns on itself. And it causes an inflammation of the synovial membrane that line the inside of certain joints. So the synovial membrane creates some lubrication, and when that gets inflamed because of an autoimmune process, we get issues. Anyone in here have rheumatoid? Okay, a couple people, and it's all women, which we'll talk about later. Alrighty. If we look at a joint, and it's kind of hard to see, I guess, because of the lights, but this is a normal joint where the bones are nice and, oh, I've noticed as I've gotten older, lighting has a big change on things. Okay, so with the joint in a normal joint, we have synovial fluid that keeps lubrication. If you can see this little line here, that's our cartilage. Our bones are nice and intact. It's a beautiful joint. Well, with osteoarthritis, that space between the two bones shrinks because the cartilage is basically disintegrating. So now we've got bone on bone. Bone on bone hurts. Bone on bone does not move real smoothly. And then if you look at a rheumatoid arthritis, the cartilage in this rheumatoid arthritic joint is actually still there. It eventually does go away. But look how swollen the joint is. And that limits our movement because of the area being inflamed. Sound good? Well, not good. That's not good. Make sense? The difference?
Lights going back on.
All right. Okay. Let's talk about our osteoarthritis first. With osteoarthritis, as we said, it's degenerative. So it is not something that overnight occurs. It starts very young and progresses as we get older. With this, as I said, it's one of our most common types. Out of that 50 million, over half of the people have osteoarthritis. Okay, so it's the most common type. And it's characterized by that cartilage breaking down, and then our bones rub on each other and they get all crumbly and not real smooth anymore. They don't track properly, and it causes pain and loss of movement. Typical places for osteoarthritis is your weight-bearing joints, so your feet, your knees, your hips, and then I know fingers aren't weight-bearing except maybe for Ayla when she's doing her handstands all the time. But your fingers are very common. For those, how many of you have some form of osteoarthritis? Okay, where are you experiencing it? Knees, fingers. Oh, you do. You have the typical fingers. Absolutely. Yeah, they hurt. I can imagine. Hips. How many of you hips? Couple. Okay. Anyone in the feet? Okay. Yeah, walking. Wowie. Can be really painful. So with osteoarthritis, if you think about it, it's a degenerative disease. And where is it happening? Weight bearing. Exactly. We got to move. We got to get around. Okay. I hate even putting that up there. It's incurable. All right. Can we help relieve some of the symptoms and the hurt? Yes. Can we stop it? No. Okay? That's the bad news. We'll get to good news, I promise. Okay. With osteoarthritis, again, it is a chronic disease. We're not getting rid of it. It causes significant disabilities in the older adult. What we feel as though, and what the research is showing, is that about 85% of individuals over the age of 70 have some form of osteoarthritis. So, in this room, raising hands, there it is. Most people during their lifetime will have varying degrees of osteoarthritis. Some mild, some can be severe. people who are obese, they tend to have 7 to 10 times greater risk of developing osteoarthritis of the knee. It's a weight-bearing joint. The knee is not a beautiful joint. You know, it's not structured really well. It's one that gets injured a lot. You know, those sorts of things. So, if you know somebody who's obese, they probably are going to end up with osteoarthritis of the knees. And osteoarthritis is responsible for more than 7 million physician visits per year. That's a lot of money in healthcare going to a degenerative disease. And then 80% of those people who have osteoarthritis say, yeah, it does limit me in some form of doing physical activity or just daily activity, getting out of bed or walking up and down stairs, your activities of daily living. So it definitely limits our ability. Osteoarthritis is generally called a wear and tear disease, and it's said to be a natural part of aging. And it's not that you're wearing out your joints. That's not what, a lot of times that's what we think, oh, I've been so physically active that I've just worn them out. And that's not really quite true. What happens is that osteoarthritis tends to develop when an enzyme that breaks our cartilage down goes a little haywire. So your cartilage, it's not just there. It breaks down and then it rebuilds. It breaks down and it rebuilds. That's what makes it soft and pliable. And as we grow older, what we find is the enzyme that helps us to do that gets a little out of sync. And what it does is it starts breaking down that cartilage a little bit faster than we can rebuild and repair. So that's what we mean by wear and tear. Not that you've used it forever. It's more of, it's a process within the body that's gotten out of sync.
Everything is harder to repair.
Absolutely. Everything is harder to repair as we grow older. All right, so when you use a joint, so I did this, I'm using my knee. Right now, my knee, the cartilage in the knee is being broken down and repaired. So enzymes are released every time a joint is used. And then these enzymes, what they do is they go in and they clean. Heidi's back there doing squats. The enzymes come in and they go, let me clean up this cartilage. It's got a little bit of, maybe a little fissure in there, a little break in there, or a little tag coming out of it. So it's going, I'm going to come in and I'm going to digest it. And then other things are coming in, other cells are going, well, while you're breaking it down, I'm going to rebuild it. Hopefully it rebuilds it to be nice and strong. But as we grow older, we can't keep up with the rebuild. So that discrepancy between the breakdown and the repair caused by excessive enzyme release, or maybe we're just slow to repair it, or maybe both, that's what's going to cause your osteoarthritis. When the cartilage is being broken down more than what we can repair it, it's not as strong. It's not able to absorb compressive forces. Okay, compressive forces, what do I mean?
Jumping up and down.
Yeah, so if I jump, that's a compressive force that my ankle needs to absorb, my knee, my hip, my spine. And when the cartilage is being broken down and not repaired, it feels that compressive force, but wow, I can't really absorb it. I can't help you with that. And what happens then is the cartilage starts to, they call it fray and develop fissures. Fissures. Weird word. But you can think of it as the cartilage starts to kind of break, develop little splits. And when it develops splits, now we're just breaking it down and it's getting into the bone. And now your bone is changing. Your bone is deforming. And now we've got pain. And again, it's those weight-bearing joints. My ankle, my knee, my hip, my spine, and then the fingers, the hands, the toes, everything. Yeah?
I have a form of psoriatic arthritis, which causes most of my knees to be replaced. That's a form of osteoarthritis, isn't it? But that's more of is that something different than what you're talking about here?
I will be honest, I don't know enough about it, because it's probably one of those types of arthritises that are not as common. I don't know a lot about that particular type.
I read that about 5% of the people who have psoriasis develop psoriatic arthritis.
Oh,
That's
okay.
true.
Okay. Yeah, and again, it could be part of an autoimmune function, and so it might actually be more related to the rheumatoid, because it has a little bit similar. When we get to that, we'll talk about the difference.
It's very similar to rheumatoid.
Okay.
Very, very similar.
Okay. All right, so let's take a look at common signs and symptoms, and let me know how many of you feel this. Joint soreness after periods of inactivity. Yep. So after you leave here, since you'll be sitting for an hour, you might get up and it's like, stretch a little bit because it's a little bit of soreness. Stiffness after periods of rest, but that tends to go away quickly once you get up and moving around. Okay. Yeah. A little more stiff in the morning, anybody? Yeah? Okay, yeah. And again, it usually lasts no more than 30 minutes. Once you get up and get things moving, you're feeling okay, a little less stiff. Pain in the joints? Anybody experience some pain? Okay. A lot of times that's caused by the weakening of the muscles surrounding the joint because it can't support that joint. We can fix that, right? Joint pain tends to be worse in the evening after you've been active during the day. Anybody feel that?
Oh, yeah.
Yeah? Okay, yeah.
Ice is my best friend.
How about anybody feel like, oh, my coordination might not be as good as it used to be? Maybe my posture, getting arounding a little bit, or walking. Walking might be a little bit, you're not feeling as though, my legs are swinging through because you have some pain. So you compensate for possibly your walking or your gait pattern. All right, let's talk about the individual areas. If you have osteoarthritis in the hip, this is what you might feel. Pain in the groin, the inner thigh, or even in the glute, right, or the backside. Okay. You might get a little bit of referred pain into the knee, meaning you're feeling it ache down all the way into the knee, or the side of the leg, of the thigh. Limping when walking. Anybody limping already? If you have it in the knees, pain when you're moving that knee, downstairs is not, going downstairs is not fun. You might feel like the knee is kind of catching, or it feels that grating kind of feeling. Pain walking up and down the stairs. People tend to tell me walking down is harder. Exactly. Getting up from a chair. So after you've been sitting here for 45 minutes to an hour, getting up might be like, oh, there it is, feel it. And then maybe even some pain that prevents you from getting the proper exercise in on that leg that you would like to. And then the thigh muscles, the quadriceps, the hamstrings, the glutes, they might be weakened because you can't get to the proper level of exercise because it hurts. We don't want to do things that hurt. Okay, if you have it in the fingers, pain and swelling of the finger joints. You might experience bony growth spurs. Typically, they're it's easier to show a picture. I'll show it in 1 second. Redness, tender swelling, and then enlarged joints. You might have difficulty with pinching, being able to pinch or to grasp something such like a pencil or a pen. So this is an x-ray of somebody who has osteoarthritis. You can see you get these little curvatures. Your fingers are exactly what it looks like for osteoarthritis. They shift. They shift because the joint capsule has been slowly degenerating over time. In the feet, pain and tenderness in the large joint at the base of the big toe. So walking, pushing off, ooh, owie, painful. You tend to walk a little more flat-footed. If you're wearing high heels or tighter shoes, you're going to feel pain. You might even experience weakness or numbness in the arms or leg because of a pinched nerve due to the inflammation. In the spine, your spinal discs start to break down. And then we get some bony overgrowth. Stiffness and pain in the neck or the lower back. Pressure on the nerves in the spinal cord. That's always not a real pleasant thing. You feel that pinched nerve occasionally that you might have. Pain in the neck, the shoulder, the arms, low back lines. Well, let's just put pain in the entire body if we get it in our spine. We have a fire alarm. This is not planned, yeah.
Well, so we have last side. Teacher.
I think we probably should follow the course of action and evacuate. And I'll investigate and then
It'll see where's your evacuation.
just go right out onto the yard, right out there.
Look at everyone moving after all that.
Howard, what are you doing today?
Come on, let's go hobble outside.
I saw you leave the other day.
Here. right on the wall.
And you can't mention that four-letter word.
Exactly.
You're at the airport, forget it.
But see, that was the cue.
You see how quick I got up.
I
was the leader
You're like, wow.
Yeah, but I don't really, it's mostly in my hands.
Yeah.
I'd like to get new hands.
It would be nice, but unfortunately not. Yeah.
Yeah, you've done
Gary.
it. Gary. Yeah.
I've seen you.
Walking the dogs. Well, so now.
Check us out how we want.
I know, that's what I'm doing, yeah.
I exercise with her.
Should I start chairs?
There's a bunch of us. We'll just go sit in the back.
Welcome back.
Well.
Yes.
Yes, and with the gold.
All right. See, that was actually my ploy to get the musical chair thing, you know.
I was scared too.
So we weren't sitting for so long. That was all me. All right, let's talk about what are some of the risk factors with osteoarthritis. Emily, let's see. Okay, try it now. There we go.
Beautiful. Age. As we grow older, we're more likely to develop it. Obesity, we talked about obesity with the knee. Okay, this one I always want to bring up. Joint injuries due to sports. Participating in activity, participating in sports does not increase your risk of osteoarthritis. However, if you've had an injury during the sport, that is what can begin the process. One, you all know who Billie Jean King is, right?
Yes.
She had terrible knees, terrible knees. And they always, you know, when they talked about, oh, you know, she played tennis and da-da-da-da. Well, they attributed her osteoarthritis in her knees actually to a car accident that she was in where she put both knees into the dashboard, not to the tennis. Yeah, so sports gets a bad name when it comes to osteoarthritis. It's not the sport itself, it's injury that occurs during the sport. So we want to continue exercising, yes.
How about surgeries?
Yes, surgeries as well. Can be definitely, anything that disrupts the joint capsule can start you on that way.
Well, so if you're like mine, I was always doing high impact aerobics, and finally I tore my meniscus.
There you go. That's an injury due to the sport, not this sport itself. Yeah. All right. Work-related activity or accidents, so that definitely will come into play as well. When you disrupt the joint, that is when you're going to start to have some issues. And then genetics. And that's where the hands come in, as a lot of times it's genetics, it's defective cartilage in the hands. All right, rheumatoid arthritis. We have 2 people with rheumatoid, correct? Okay. All right, so rheumatoid. Much less incidence of rheumatoid, but it's the second most common type of arthritis. Osteoarthritis, main type. Rheumatoid are second type, or second most common. But only about 1.5 million Americans have rheumatoid or have been diagnosed with rheumatoid, and they are mostly women. 70% of those people with rheumatoid arthritis are women. With it, however, if a man gets rheumatoid arthritis, they are more severely affected by it. More women have it. Men, if you get it, you're going to be more severely affected by it. Typically, the onset for rheumatoid arthritis is middle age, 30 to 50. But that's what they call it.
That's what my 23-year-old would call it.
Yeah, exactly.
Oh, you might just say old.
So with this, this is when it's typically diagnosed in between the ages of 30 and 50. But some people are diagnosed very early on. They're diagnosed in their teenage years. The problem with rheumatoid arthritis is, yes, it's a debilitating disease, but your death rate or your death year tends to be a little bit earlier than somebody without rheumatoid arthritis. And not just a little bit, a full decade, decade and a half is earlier you can expect to die, unfortunately. And that's because rheumatoid arthritis not only affects the joint, but when it becomes severe, it goes into all systems and it can affect the heart, the eyes, everything. Yeah, Will was right. With rheumatoid arthritis, if you remember from the beginning, we talked about its inflammation of the synovial membrane that lines the inside of certain joints. So it's an inflammation. If you'll notice in this, the hands tend to be swollen. Okay? When that inflammation occurs, inflammation you can think of as like these little bugs, right, that come into the joint. And what they do is, now that that synovial membrane is inflamed, it says, I'm not happy with just inflaming this membrane. I'm going to seek out and I'm going to start to destroy bone and cartilage. So they don't stick to that membrane. Once the rheumatoid becomes severe, they start to branch out and look for more tribes to attack. With these inflammatory cells, they release the enzymes that start to digest the bone and the cartilage. They're reaching out past that membrane. And then what happens is the joint, because you're destroying or dissolving bone and cartilage, it starts to lose its shape and it becomes very misshapen, and it starts to lose alignment. So instead of rocking back and forth real nicely, now it's like this, and it's not hitting where it should be, and it causes pain and, of course, loss of movement. So with rheumatoid arthritis, it's a little different. When we said osteo, we said cartilage. Well, the rheumatoid arthritis is actually in the synovial tissue that lines the outside of the joint, and then it progresses to deteriorate the cartilage. So it starts in the membrane, goes to the cartilage and to the bone. The osteoarthritis starts at the cartilage and might work its way to bone. What we see is that with this inflammation, every time that the joint becomes inflamed, and it's not 24 hours a day, every single day, every year. There are periods of flare-ups, and then it goes into remission, if you want to think of it that way, or it dies down, and then you flare up again. And every time we flare up, every time we have that inflammation, that is what's going to lead to the gradual destruction of that joint. Scar tissue is eventually going to form in that area. Scar tissue is extremely challenging to get rid of. Now, with rheumatoid arthritis, here's the problem with it. It's a little challenging to diagnose. Osteoarthritis, how do you think we diagnose that? MRI, X-ray, looking at it going, oh yeah, that doesn't look so good. All right. Rheumatoid, a little bit more challenging. You need to have at least 4 out of these 7 symptoms to be classified as rheumatoid arthritis. One of them is morning stiffness that lasts for several weeks. You need to have arthritis of 3 or more joint areas. So it's not limited to the knee. Arthritis of the joint hands. That's another one that becomes real clear with rheumatoid. Symmetrical arthritis. This one to me is fascinating. Okay, osteoarthritis, it's in my right knee. Good. Rheumatoid arthritis, if my right knee is involved, my left knee is involved. It's symmetrical on both sides of the body. That one just fascinates me for some reason.
That's how I knew what it was.
Okay.
You know, I had other stuff, and I just said, it's middle age, and I had knee issues anyway. But it like started in one finger, and within a month or 2, it was over, and then it was both hands,
Yeah.
and then both knees. absolutely, they were bizarre.
Yeah, it's really a fascinating kind of classification. Rheumatoid nodules, these are like little bumps that you get onto, especially the hands. And then there is a test, a serum rheumatoid factor, that we can take a blood test and say, do you have the rheumatoid factor? However, not everyone with rheumatoid arthritis has this rheumatoid factor, right? So it would be lovely if everybody did. We just did a blood test, bam, you got it, or you don't. Unfortunately, it doesn't work that way. Not everybody has that rheumatoid factor. And then seeing changes on an X-ray or an MRI type of thing. You do not have to have all of these. You need to have 4 out of the 7, 4 or more, to be diagnosed as having rheumatoid arthritis.
When I had all the exclusion things done for fibromyalgia, I felt self-assured I did not have rheumatoid because of the blood test. So that was fallacy.
Yes, it is, because not everybody carries that rheumatoid factor. Yeah. So if you're looking at this going,
Yeah.
you might want to go back and say, you know, I was at a lecture and this was the criteria, and I'm wondering.
I'll ask them.
Yeah, I'm wondering.
Because
They
it
might
does
say-
make me wonder.
Yeah, and again, it could be, no, you don't have enough, or you don't have, it doesn't last long enough, or whatever it may be.
Okay,
Yeah.
thank you.
You know, I think that's one of the things, it took about 6 months for me to be diagnosed, and it does, and I have a sister who has very similar, and she has been on both sides, but she does not test positive for RA factor, so they said, oh, it's fibromyalgia, it's not fibromyalgia. I'm really strong, especially as RA.
It's hard to
And
diagnose.
so I would, you know, I would say to your doctor, you know, keep investigating, keep going, and it's become more well-known in the past few years about the RA factor.
Absolutely.
So,
What's the sensitivity of the serum blood test?
That's a good question. I do not know the answer to that, and I suspect as time goes by, we'll get better at it.
So it's still in the first generation?
I wouldn't say that, because these criteria were set forth in 1987. Was the first time that they put those through. So it might, as time goes by, we get a little bit more sensitive in the testing of it, that they can go, well, now if you have that factor, yes, if you don't, no. But it's still being developed. You know, we're still working through it. And so rheumatoid arthritis, like I said, once we get down to a blood test, that's fantastic.
yeah, one of the other things too is that I was tested, sports, arthritis doctor, and came back and told me I was fine. And I said, well, how come I hurt from my neck down? And one day it's this shoulder, and one day it's this hand. And they said, well, you need to have a good physical. And actually the person who diagnosed me was my internist. And she looked at it, and she said, well, you know, your inflammation's up, and I mean, it wasn't super high. She did a more significant blood test, tested a few more things, and it was a combo, so it wasn't even just this, it was something else tying in with it. And I had suspected that's what it was, and I literally, I was on medication, and a week later I was feeling so much better.
Yeah.
So it was needing more tests, and nobody was willing.
Yeah, and sometimes you just have to investigate a little bit more.
Could or would a bone density test help to diagnose either one of them, or be a factor of consideration?
I don't know if the bone density test would be, because the bone density test might only look at one area. For example, it's not going to look at a knee. It will look at the hip, it will look at the spine or the wrist. So if it's not in that area, you won't be able to tell.
And there's a lot of reasons for bone density issues anyway. We're past.
Exactly.
I think you said before you could have these and they go away and then they come back. Because I think I had those nodules, but I don't have them now.
Yeah. Typically, if it's a rheumatoid nodule, it's going to stay around. Typically. But it could have been something else, a different type of nodule or something else that was going on. But like the flare-ups where you're in the most amount of pain, those come and go. They come and go. And you never quite know when it's going to hit. So again, if we look at a picture, here's our normal joint. Everything's kind of nice and easy. But now look here at the inflammation, the swelling. of that joint. And then the swelling of that joint starts to eat away all these little things of the cartilage and the bone, and now we're having limitation of movement. Here's some of the symptoms with rheumatoid arthritis. So pain, well, it's the same as osteo. Decreased range of motion, joint instability, muscle weakness, diminished endurance, meaning that you might not be able to last as long at an activity. That's kind of a tongue twister. Tenderness, warmth, and swelling and redness. And then other people might have other symptoms. The eyes can be affected with rheumatoid arthritis, where blindness may eventually occur. Okay, so when you have whatever type of arthritis it is, the big thing is pain. And the big thing is that it doesn't feel good to move. So what do people do?
You said,
You don't move, exactly. I mean, we're not dumb. We try to avoid pain, you know. Let's have some weird things.
that's the worst thing you could do.
So when we sit and we don't move, here's what happens. We see the muscles, the tendons, the ligaments, the bones, they start to fade away. That's not good. We don't like that. We get weakness. You're not as strong as you used to be. You know, move, you're going to lose it. Development of contractures. Anybody know what a contracture is?
No.
Brings things together.
Yeah, it brings things together. So, for example, how many of you have ever broken like an elbow? Anybody break an elbow? Okay, I've got one. You're in a cast. When you get out of that cast, can you straighten that arm? No. Why? Yeah, it's a contracture because things have shortened. Everything's kind of tightened up a little bit. So with arthritis, or when you're not moving, things shorten and your range of motion declines. And so you have trouble moving properly. It doesn't feel good to move. So development of contractures. We don't want that. Hands, you know, the hands become shortened. The fingers, I should say, become shortened and bent. The knees might not fully straighten. The elbows might not fully straighten. The wrists might not fully straighten or have the full range of motion. The joint cartilage is going to degenerate as you're sitting there. And then we're not moving, osteoporosis. We don't want to lose our bone density. It's really challenging to gain anything back on that. All right, I want to talk about a pain rating scale because I love this scale. With the pain rating scale, it is for you to assess how are you feeling today. And it's important for you to know this because it will dictate what you should do in an exercise or activity. So, real quickly, if your joints are warm to the touch, or they're red, or they're swollen, you should not exercise those joints vigorously. Now, I didn't say you shouldn't exercise those joints. We want to move those joints. But we don't want to do it really fast and furious. We want to give them a little chance, but we still need to move them. But if they're warm to the touch, red or swollen, back off a little bit on what you're doing. This one I love. This is a good rule to follow. If your overall joint pain is worse at the end of your workout than when you started it, wait 2 hours, reevaluate. If it is still worse than what it was when you started, you're going to probably be overdoing it. And you need to either tell your trainer, or you need to, if you're exercising on your own, you need to remind yourself, I need to back off a little bit. That was too challenging for the joint. So with this, we get, the pain scale is like 0 to 100, which I think is kind of funny. 1 to 5 works for me, okay? 1 is no pain, 5 is intense pain, middle, moderate. Okay, so what we want to think about is when we start that workout, before we start, let's choose the knee. My knee's bugging me. It's not red, it's not swollen, it's got a little bit of pain. I'm going to rate my knee on a 1 to 5. Where is it? I'm about a 2 right now. Okay, I'm going to do my workout. My pain's now a 3 after my workout. All right, I'm gonna wait 2 hours and I'm gonna reevaluate. I've gone back down to a 2. I'm good. My knee, or 2 hours later, my knee pain is still at 3. I need to back off. It's a very simple system for you to use when you're exercising. If you're at the same pain level that what you were before, you're good. Some people actually feel a relief from pain. Love that. That's even fantastic. The concern is if you are in greater pain after the workout, wait 2 hours, take a look at it again. If it's still worse than when you're at that beginning, back off. Let the trainer know, let your group exercise instructor know, or if you're working out on your own, I need to back off. Super simple system. So my suggestion is have a little notebook, rating the pain scale, figuring out what makes it worse, what makes it feel better. Sometimes it's a fluky thing that, well, I always do this, but today it's a little worse. All right, let me back off the next time, see how I feel, and then I can move forward again. Good on that? 1 to 5. Right here, I can use my hand. All right. So when we're exercising, what are our goals? Well, big one is to preserve or even restore the range of motion. I want to be able to move instead of, just here, I can't lift my leg anymore. I want to get back up to where I should be moving. I want to preserve this range of motion, improve that range of motion. I want to increase my strength and my muscular endurance so that the joint becomes more stable. When we got weak joints surrounding our knee or our hip, it creates instability in the joint. It's not going to track properly. So with that, we want to make sure we strengthen that area. So muscular strength activities or muscular endurance activities, we need to think about, I need to work on that area surrounding the joint that's affected. And then I want to improve my aerobic ability, my cardiovascular endurance, because that, one, just helps decrease the risk of other diseases that we have, stroke, heart attacks, hypertension, and it also improves our psychological state. Didn't mean to do that. Okay, so let's talk about some general guidelines. Things to think about when you are being active with your arthritis issues. One is if you have osteoarthritis, remember that's weight-bearing joints. Participate in low-impact activities. So we can limit or we can alleviate some of the impact on an unstable joint. So low-impact activities. Begin with low-intensity but frequent sessions. We would rather you exercise maybe twice a day for 5 minutes to see how you handle it, to see how that joint handles it, as opposed to 30 minutes all at once when you're starting out and you're testing what your limits are with that joint. If you have periods of pain or inflammation, reduce the intensity and the duration. But I didn't say stop. We don't want you sitting down on the job. Okay? The joint needs to move. We
can stay there because they said it was up to us if we evacuated.
Okay.
So if you want to try to
I can do it. I can do it.
let's do it.
I was going to say, somebody doesn't want to do finals or?
Yeah, exactly. All right, so take it easy during those times of inflammation or pain. Do not stop. Do not crawl into bed unless, of course, it's so severe, but then I'd be calling the doctor at that point. You do sit down. When you have a joint that has arthritis, take a little bit longer of a time to warm up. Start a lot lower, take more time to get the area moving properly. And then take a longer time to cool down. So your time that you're doing your training might be shortened a little bit. But it's okay to protect that joint, to make it work so that you aren't in greater pain later on. Give it time to adjust to what you're putting it through. And then again, depending on your level, adjust. Adjust, adjust, adjust. as much of a pain-free range of motion as you possibly can. All right, so if you've got that pain that didn't go away or that was worse after the workout, let yourself a day or two of rest, of intense activities. Use that 2-hour pain rule to kind of adjust the intensity, but still move through the range of motion. It might be at a much lower level. So for example, instead of going through a crank cycle class, you take the chair yoga or the flexibility, I can't remember what that name of the class is called, the flexibility class.
Yeah.
Right? You do that. Change it up a little bit. Your full range of motion. Right? You're taking the intensity down. Proper body alignment at all times. Yeah, that one's a challenging one because we, as we grow older, a little bit out of alignment. That's okay. We want to focus on, if I'm going to stretch, I want that proper alignment as best that I can achieve it with my arthritic joint. Now, pain is normal for those of you who have arthritis, who live with it almost on a daily basis. Some days are worse than others. When you have that pain, we don't want to push you past it. So keep in mind, listen to your body. Let me work below that level of pain. We're not striving to go to the Olympics, all right, where we really work up to that point. We want to be below that point of pain. And again, if severe pain persists, you need to go to the doctor, okay, and work with the physician. Flexibility exercises. This is for that particular arthritic joint. This is the key. This is number one thing that you should be thinking about. If you do an exercise that causes immediate pain, or the pain is worse and it stays worse 24 to 48 hours, we need to discontinue that particular activity, that particular exercise, if you can pinpoint what it was. We also need to distinguish between soreness and pain. How would you describe pain?
Intensity.
Intensity. Sharp, right? Yeah. It's like, how would you describe soreness? Aching. Yeah. Kind of like, you end up doing this a lot when you're sore. Have you done that before? Okay. I don't know why we do that. It's like, ow, and you're still poking yourself. Because soreness is okay. Pain is not. We typically say soreness is within the muscle. Pain is within the joint. We don't want pain in the joint. In arthritis, you live with pain in your joints. But when you're looking at an activity, make sure you're distinguishing, did that cause more pain or did that cause soreness within the muscle? Really important to distinguish between the two. If you can, you want to warm the tissue that surrounds the joint, and it might make the exercise feel more tolerable. Now, we can do that through a proper dynamic warm-up while we're moving. You can also do this through heating pads, or how many of you have had the heating pads that you throw in the microwave? I can't remember what they're filled with. Beans or something. Rice or something. To surround the joint, say the knee or the hip, and then do your proper warm-up. It might make it more tolerable. For your fingers, that warmth might make it more tolerable, and that's okay to do. It doesn't replace your warm-up, that dynamic warm-up that we're putting you through till we get to the intensity, but it might make it a little bit more tolerable to you as you're going through that warm-up. Everybody has an individual threshold for a static stretch. What's a static stretch? Right, I'm going to go into this position, I'm going to hold it. Now, some people are going to be way out here. Some people are going to be way here. That's okay. Remember, keep in mind, we're not competing with the person next to us. Everybody has their own things that are going on, their own feelings inside. So keep in mind, just go to your point below the pain. Make sure your exercises are performed correctly. That's why attending those classes here at the Life Fit Center is fantastic. You have people helping you with proper body mechanics. Resistance exercises, definitely, we can see gains in strength with individuals with arthritis. Okay, this here's a really big sentence. I'm going to break it down for you. Starting with isometric exercises. What's an isometric exercise? Holding, exactly. So, if I do this, and I'm pressing hand against hand, this is an isometric exercise. Okay? When I do this, and I have a weight, lying down, got a weight, that's what we call an isotonic exercise. With your arthritic joint, what you might want to try first is isometric exercises to improve the strength of that area before you go to movement. So if I want to work on, say my knee is arthritic, if I want to work on strength, it might be beneficial for me to grab this ball, put it against the wall, and I'm going to push. Right here, I'm building strength around that knee joint. Okay? Or I'm going to lay down and squish it between my legs. That's an isometric that can be more tolerable to that arthritic joint as opposed to sitting on a leg extension machine, a leg press machine, a leg curl machine. So you need to think about how is my joint affected? The staff here can help you with those isometric exercises surrounding that joint. It's beneficial for you to try those prior to going to movement if you have pain in the joint. You will build strength in that area, which is fantastic. We can protect joints by using machines once we've moved off the isometric and you're on the machines, or if you have arthritic hands, to use straps so that the bars don't slip out. We always want to be a little careful with straps, okay, because we don't want to have too much weight on it to pull it too hard. But if you have arthritic hands and you can't hold on to something, it gives you a little sense of accomplishment, or a little sense of safety, I should say, to help. All right, aerobic activity. With this type of exercise, when you have osteoarthritis, especially because those are your weight-bearing joints, we get a lot of compensatory movements. What do I mean by that? Yeah, okay. Right now, I got a boot on my foot. I have to make compensatory movements when I walk. So when I walk, I am having to actually like pull my leg through. Okay? That's not a really efficient way to walk. And so with this, when we do that, when we have arthritis in the hip, the knee, the feet, we are not moving properly. Our body will adjust to be able to make us move, but it might not be so efficient. So when you're looking at what type of aerobic activity to do, if you have it in the hip or the knee, maybe you should go to the crank cycle. If you've got it in the shoulder, maybe you should be on the bike so that you're not making these adjustments that can cause a cascading effect somewhere else. Right? So when we think about which ones should we choose, there's a lot of options for us for upper body, lower body, the pool. That might be a great choice for you so that you're not, as I'm doing this and I'm limping across, you know what's happening with this hip? Exactly. It's really tired by the end of the day. Type of thing. So we don't want to cause another problem somewhere else because of what we're choosing to do. Okay, some guidelines for their cardiorespiratory activities: smooth, repetitive motions for that arthritic joint. If we have arthritis in the knees and the hips, that probably is not the best thing to do some plyometrics or some jumping activities. Okay? Smooth, repetitive. Avoid high impact activity on that joint. Now, if you have no problems in the lower body, some jumping activities, great. If it's all up in the shoulder, you're not using that shoulder to lift you too hard and land too hard. Circuit training, so resistance training on the machines in the circuit can actually provide you aerobic benefit if that helps with avoiding the area that hurts. And then, again, forget so much about the intensity. It's how long you do it and how often you do it. We can get benefits with duration and frequency and avoid the high intensity that would affect the joint, that would cause possibly more pain in that area. Okay, a couple more things. Big finish slide here. All right, so increasing frequency. We want to start with, let's try to get 3 days a week in if we can, and that's range of motion or aerobic or resistance. Goal of 5 to 7 days per week for that, especially the range of motion activities. Intensity, we can use heart rate or we can use rating of perceived exertion, that 1 to 10 scale, how hard do you feel you're working. And keep in mind that for those rating of perceived exertion scales, it's very subjective. So if the knee or the hip or the back is bothering you one day, it's going to feel harder as you're working out. That's okay. Lower things down. Keep in mind, we work not to that point of pain. We want to work below that point of pain. Duration. We want to increase our duration as best we can, but a couple things to keep in mind. If I increase the time I'm being active and I have more pain, not so great. We want to live as low pain level as possible. So be careful with your duration. You can increase how much time you spend working out if the symptoms do not increase for 2 to 3 consecutive exercise sessions. Give yourself some time. Don't increase every time you're here. Give yourself some time. With this, keep in mind that 2-hour pain rule. I love that system. Rate the pain of that joint. Complete your workout. Immediately following, rate it again. If it's higher, give it 2 hours. Check again. If it's still higher than what it was pre, you need to back down. If we start the exercise session and we're at a 2 and it stays at 2 afterwards, you did good. You did really good. If you decreased it, you did fantastic. And then again, begin slow and slowly accumulate up. Ta-da! Do you have questions? I know we're kind of over because of fire dress. Yes.
The exercises for example, Zumba, is that okay?
With the Zumba, love it. Instructor, teach several times a week. If it does not cause greater pain, then it's probably okay for you. If it causes greater pain, you either need to modify it or you might need to remove it. If it doesn't cause you greater pain, you're good. Yeah.
Because I have arthritis in my knees.
And make sure you have the right shoes, too, the pivot shoes. Every time. Yeah, I'll take a look at your bottoms in a second.
You mentioned that all joints should go through a full range of motion once a day. What might be some joints that we might normally or commonly forget about doing that with? Can you demonstrate one?
I'm trying to think what people forget.
How about hands?
Hands, yeah, hands. I mean, it's if you think about it when you're doing it, if you go from head down to the toes and you just kind of, it doesn't need to be anything really dramatic. It's, here, shoulder rolls. That one. Yeah, from head to the toe, think about just moving. The idea is to move through the full range of motion every day. And those arthritic joints, if you have a hip, I'm going to focus a little bit more on my hip. Maybe do a couple of extra activities, and I'm going to do my hip twice a day.
And also paraffin wax is really
Because the heat.
excellent.
Yeah, paraffin wax works
Feet
very nice.
and hands.
It creates that warmth. Again,
Put
that
your hands in.
at the
Paraffin wax
manicurists,
Not all of them,
some of them do. Yeah, you can
But you
dip
can buy them.
Oh, never tried that one.
Can you also go, is that not a range of motion though, going up and down?
Yes,
Your knees,
so
or
here,
is it-
this is a range of motion, absolutely. It doesn't have to be, I'm going to sit and I'm going to
Side to
hold
side.
this. It can be any type of dynamic movement that you are moving through a full range of motion. Yeah.
You've been talking about heat, but when do you recommend quote ice versus heat? Seems like there's always a controversy about that.
Yes.
There is a big controversy about that, and it really depends upon on your physician of what they suggest. Typically, I'm a big heat person. I love the thought of when you have cold, ice on the joint or ice on a muscle, it shuts it down and the blood flow doesn't get to that area. Mm-hmm. I'm a big proponent of let's heat it up so I can get the blood flow in there, clean all out the blood, because the blood's going to clean up all the things that are going on in there and take it away. But there's a lot of controversy in the area. Yeah. So, you know, a lot of times what they say is right after an injury, ice is best because it keeps the inflammation down, and then you move on to heat. I have a heating pad that is a therapeutic heating pad that I love this thing because it goes higher than a normal heating pad. You have to be a little careful with it, but it to me that I'm a big proponent of heat, but don't take my word for it. So it's really a big. Typically, when there's a lot of inflammation, ice has been suggested alternating with heat, so that you get blood flow in there to clean it out. Then you get the ice in there to kind of reduce the inflammation, so it's not so bulky of an area. And then the heat again. Yeah. So maybe someday we'll have a definitive answer, but
We'll be gone by then.
yeah, I'll probably be done by then. Other questions? All right. Well, thank you so much for allowing me to come in with our fire alarms and everything.
What's the name of your heating pad?
I can't remember it, but oh yeah, don't leave. Emily's telling me don't leave. I will try to remember tonight to look at it and give it to either Ayla or Emily.
You can use it every day. It's worth it.
Yeah. So
You know,
let me send myself an email so I remember to look.
and I could write down my email for you.
Yes, that'd be great. And then I can just email you.
I guess it's continuing around the back.
Emily, if we have extras,
I need another one. We're around.
thank you so much.
Thank you. I've got to thank you.
What was your name?
I'm Jan.
It's Molly Nelson, 86.
Okay. Perfect. Okay. I will so much tonight and get back to you.
Yes. Oh, you're welcome.
All right. You're welcome. I'm going to go have some lunch.
I appreciate it. Awesome. Good job. Thank you.
Very good. How do you spell your last name?
S.
The one I recommend is a program like that.
Now that I just like that a lot. Thank you. Yes, beautiful. Thank you. I think there are some folks at Memorial that we can reach out to, or Memorial Healthcare. So that might be a good option.
Yeah, it would be, because it's, like I asked, how do you differentiate between COPD? Depends on what smoking it takes to COPD.
Yeah, good one. I like that. But I know it's Jan Schroeder, but
Hey, you're looking mighty blue. Yeah, I like your outfit. That's great. Yeah, my grandpa likes it to me. Good taste.
Their niece is also pregnant, so I think on Sunday we're all staying.
I teach it privately with my children.
When's my next class?
What class is that?
I'm going to the travel.
I know, it's awesome.
Over, yeah. It's at 1:30 and
You were my choice, it was
free. No, it's over the main 101 or whatever that is.
Oh, no, but I mean, it's here.
Yes.
It's not over.
Right, no, it's here. I went to that yesterday. Right. This is just for that, right? I think it's, yeah. 1:30 at 101.
I kept putting it on in different ways, and I was like,
I'll let you know if there's anything really interesting on that one.
yeah, and we'll see. And then you're like,
I need to come back to your class.
The flexibility, mindfulness, and gratitude.
Yeah, well, I was so regular. And then this came up at 11 o'clock, and so now I'm going to put it back on. Put me back on your calendar.